Good day, everyone. We are the Groups GxH of MSc-COM's Nephrology Module 2021, and we'll talk about renal tubular reabsorption and secretion with their associated clinical and pharmacologic correlations. 40 plus overwhelming pages from all these sources, we got you for less than 2 hours. So, to keep you hooked with us, let us have a little game. We've put a few secret messages all over this presentation. If you find them, message any of us on Facebook and we will give you corresponding prizes. Enjoy the treasure hunt! That said, we're only 2 weeks away from exams, so let's start with a quick intro. The basic unit of the kidney is called a nephron, which is made up of a glomerulus, which filters the blood, and the renal tubule, where the filtered content goes through. Along this course, some substances are selectively reabsorbed from the tubules back into the blood, while others are secreted the other way around. This functions to maintain homeostasis, or the balance of fluid and ions in our body. The renal tubule has a few segments of its own: the proximal convoluted tubule, the U-shaped loop of Henle with a thin descending limb, a thin ascending limb, and a thick ascending limb, and finally the distal convoluted tubule, which empties into the collecting duct, which collects the urine. Among these, the S3 segment, distal segment that is, of the PCT, the loop of Henle, the medullary collecting tubule, and the collecting duct are all located in the renal medulla. As the renal medulla is the first portion affected by renal ischemia due to low blood flow around this area, during such a case, the first to be affected are the tubular segments here. Renal ischemia is a cause of intrinsic renal azotemia. Meanwhile, in the case of obstructive uropathy, a condition that can cause post-renal azotemia, there is a progressive distoproximal dilation, first the collecting ducts, then the DCT, and so on and so forth. This happens around 3 days after complete obstruction, and with urine stasis comes the risk of acquiring infections and chronic tubular atrophy with little glomerular damage. Both subdivisions of azotemia, with another one that is of a pre-renal etiology, will be discussed further later. Anyway, in summary, the formed urine and all its substances represent the sum of the 3 basic renal processes: glomerular filtration, tubular reabsorption, and tubular secretion, as shown by this formula. Now, let's dive in. To appreciate the magnitude of tubular reabsorption, look at this table and compare the amount of substances that are filtered, reabsorbed, and secreted in the urine. You can see that the processes of glomerular filtration and tubular reabsorption are quantitatively large relative to urinary excretion for many substances. And, unlike glomerular filtration, which is relatively non-selective, tubular reabsorption is highly selective. How so? Check out glucose, for example. Remember that the glomerular filtration barrier's minimum threshold is 70 kilodaltons of molecular weight. Glucose is ridiculously small, only at 180 daltons, hence readily filtered. But it's gravely needed by the body, the first priority macromolecule to be catabolized for the body's energy needs, in fact. And thus, it is to no surprise that in normal cases, all of glucose is reabsorbed back to the bloodstream. Sodium is an ion, therefore even smaller than glucose, and is even cationic at that, so it goes straight to the tubules. However, the extent to which the tubules reabsorb it varies, as many of the body's regulatory mechanisms, to be discussed later, dictate how much sodium is to be reabsorbed and secreted. Can't have too much in our body anyway. Here's urea. This molecule exists because the product of protein metabolism, ammonia, is toxic almost anywhere in the body, and your kidneys are no exception. Thus, ammonia undergoes the ornithine cycle, also known as the urea cycle, to form, well, urea, now essentially a waste product. You heard it, waste. Therefore, we can see that it's a 1:1 reabsorption to excretion ratio in the case of urea. Lastly, we have creatinine. As it has a low molecular weight, it is readily filtered. However, it is a waste product of creatine metabolism in muscle. It is also relatively larger than urea, thus impermeant to any part of the tubule, and approximately 100% excreted. Any damage to the nephron, therefore, causes increased amounts of creatinine and BUN, a condition called azotemia, as we will discuss later. So the principle behind tubular reabsorption is basically this: if your body needs it more, the tubules will reabsorb it more. If your body doesn't need it, the tubules will excrete it. Now, for a substance to be reabsorbed, it must first be transported towards the tubular epithelium into the renal interstitium, and then through the peritubular capillaries back into the blood. This can be done in various ways. Molecules can utilize either the transcellular route, where they pass through the apical, then basal surfaces of the tubular cell membrane, or the paracellular route, where it goes through the space between the tight cell-to-cell junctions. Sodium, for example, is mostly transported through the transcellular pathway, whereas calcium and magnesium ions are carried to the interstitium via the paracellular pathway. Transport can also either be active against an electrochemical gradient and requiring ATP, or passive towards an electrochemical gradient and not requiring ATP. We will expand on this shortly. After tubulo-interstitial transport, water and solutes are transported through the peritubular capillary walls into the blood by ultrafiltration or bulk flow, which is mediated by hydrostatic and colloid osmotic forces. Once again, active transport moves the solute against an electrochemical gradient, thus requiring ATP. It is done either by directly coupling to an energy source, also known as primary active transport, or indirectly, which is in the case of secondary active transport. The energy for primary active transport comes from ATP hydrolysis by way of membrane-bound ATPase, which is also part of the carrier mechanism that binds to and moves solutes across the cell membrane. Every active renal transporter suffixed with ATPase utilizes this type, and that includes the sodium-potassium ATPase, hydrogen ATPase, and calcium ATPase pumps. Notably, the sodium-potassium ATPase pump, located on the basolateral sides of the tubular cell, provides for cellular transport of sodium and potassium against their respective electrochemical gradients. Sodium ions are transported from the cell to the interstitium, and potassium is transported vice versa. The resultant intracellular net charge, therefore, ends up being about -70 millivolts. Another result of this exchange is that sodium can now also either passively diffuse or undergo facilitated diffusion across the apical or luminal membrane of the tubular cell because of two things. One, the intracellular sodium concentration is now lower than that of tubular fluid. Two, the negative potential of the cell attracts the positively charged sodium ions from the lumen. In secondary active transport, on the other hand, two or more substances bind with a carrier protein and are transported together across the membrane. To make it sound easier, this happens after the events of primary active transport. A well-known example is glucose, which moves along with sodium after the latter goes inside the cell thanks to primary active transport. On the apical membrane of the PCT cells, there are sodium-glucose cotransporters, SGLT2 in the PCT's S1 segment, and SGLT1 in its S3 segment. The basolateral side, on the other hand, has glucose transporters, GLUT2 in the S1 segment and GLUT1 in the S3 segment. Now, as sodium goes inside the cell from the tubular lumen, thus moving down its electrochemical gradient, the energy released by the primary sodium-potassium ATPase pump, as described a while ago, will indirectly contribute to glucose co-transporting with sodium via the SGLTs 2 and 1. This time, glucose moves against its concentration gradient, considering that there is typically more glucose inside the cell than outside. It is to note that 90% of glucose is transported by SGLT2 and 10% of it by SGLT1. After that, since glucose is now heavily concentrated in the cell, it undergoes diffusion into the interstitium, facilitated by the GLUTs 2 and 1. Same values, 90% via GLUT2 and 10% via GLUT1. And summating the numbers gives you 100%. Just as we have said a while ago, in normal cases, all of glucose is removed from the tubular lumen, magnifying the efficiency of these transporters. Now, let's talk about secondary active secretion, often involving counter-transport of a substance with, once again, sodium. Same precedent. Sodium goes down its electrochemical gradient, entering the cell, but now we'll involve a different transporter, the sodium-hydrogen antiporter, which exchanges sodium going inside for hydrogen going outside to the lumen, the latter process being against its electrochemical gradient. There's also another form of active transport called penocytosis, colloquially called cell drinking. As some proteins can get through the glomerular filtration barrier, some of them would attach to the apical surface of the tubular cells, and that part of the membrane then invaginates to inside the cell until it is completely pinched off, forming a vesicle containing the protein. Once inside, the protein is digested into amino acids, which are then reabsorbed through the cell's basolateral surfaces into the interstitium. As with all processes in the body, there is a limit to how much of the solute can be transported, termed its transport maximum, henceforth referred to as Tmax. When the amount of a solute in the lumen, which is the tubular load, goes way past the capacity of the processes involved in its transport, these systems will end up being saturated at one point, unable to cater to the excess. Any excess of a solute beyond its Tmax, therefore, is not reabsorbed and passes into the urine. A factor affecting the solute's Tmax is its renal threshold, determined by the amount of solute present in the plasma. If plasma levels of a solute are deemed more than sufficient to maintain the body's processes, the renal threshold is reached. Thus, any amount of a solute in the tubular lumen need not be reabsorbed further. Glucose, for example, has an average Tmax of 375 milligrams per minute, while the upper limit of its renal threshold is 200 milligrams per deciliter of plasma, as you can see in this image. In patients with uncontrolled diabetes mellitus, the renal threshold is reached, thus causing glycosuria. The question now is, why is the renal threshold reached before the Tmax? Shouldn't they happen at the same time? The answer is no. Remember, there are different kinds of nephrons. Glucose's Tmax is merely the average and representative of all nephrons, not each nephron in the kidneys. Thus, some nephrons with a lower individual Tmax begin excreting glucose before others. Here are the transport maximums for some substances actively reabsorbed. On the other hand, here are the transport maximums for substances actively secreted. If the processes involved in its transport to the lumen end up being saturated, there won't be any room for the excess, so they remain in the plasma. Note, however, that this is heavily exceeded only upon tubular damage, as products that are to be actively secreted are either waste products like creatinine or exogenous compounds like para-aminohippuric acid, both of which we'll expand on a little later. There are substances, though, that do not demonstrate a Tmax. It's because their rate of transport has the following factors. Substances that rely on these factors rather utilize the gradient time transport principle. Our all-time popular example is sodium reabsorption in the PCT, where the max transport capacity of the sodium-potassium ATPase pump is greater than the net sodium reabsorption rate because lots of sodium transported into the interstitium leaks all the way back to the tubular lumen through cell junctions. The rate at which this backleak occurs depends on tight junction permeability and interstitial pressures, which drive ultrafiltration to the peritubular capillaries. Sodium reabsorption in the DCT, on the other hand, exhibits a Tmax, because here the cells have tighter junctions and transport smaller amounts of the ion. However, unlike the previously mentioned substances with a Tmax, sodium's Tmax is not absolute. It can be increased by some hormones, like aldosterone, which we will talk about later. The aforementioned transport mechanisms cause a subsequent concentration difference between the tubule, now with decreased amounts of solute, and the interstitium, now with increased amounts of solute. As most of these solutes are osmotically active, especially sodium, the phenomenon drives the osmosis of water from the tubular lumen into the interstitium, and mainly facilitated by membrane aquaporins, AQP1 being always in the membrane, and AQP2 having a varied activity, depending on antidiuretic hormone, which we will talk about later, and tight junctions. This highlights the differences of water permeability across the different tubular segments, to be explained as we proceed to discuss tubular physiology segment by segment later. Anyway, what can do osmosis the other way around, that is, driving osmosis from the interstitium to the tubule, are osmotic diuretics. Many ions end up being excreted in the urine, but water is driven out the most. Mannitol is the most common drug in this class. Others include urea, yes, urea, administered intravenously like mannitol, and glycerin and isosorbide, which are administered orally. They mainly act on the areas where water reabsorption is greatest, the distal segment of the PCT and the thin descending limb of the loop of Henle. The main indications for using osmotic diuretics are conditions where interstitial fluid overload is extremely critical. This includes glaucoma, where fluid in the eyes is in excess due to aqueous humor buildup, a case of increased intraocular pressure, and cerebral edema and traumatic brain injury, conditions that cause fluid buildup in the cranial vault and lead to increased intracranial pressure. Because of osmosis, fluid is driven out of these areas, causing a decrease in the pressures. Prolonged usage of osmotic diuretics cause side effects that are more or less the same with the other diuretics: dehydration and electrolyte imbalance, especially when unchecked. Also, like other diuretics, they are contraindicated in cases of dehydration, but unlike other diuretics, they are contraindicated in conditions manifesting with extracellular fluid overload, such as acute kidney injury, severe chronic kidney disease, heart failure, pulmonary edema, and liver cirrhosis, as these diuretics will end up worsening these situations. Having heard the gist of sodium reabsorption prior, now it's apparent as well that the resultant potential of the tubular lumen is negative, and with subsequent water reabsorption, the concentration gradient increases. Thus, to contribute to electrochemical neutrality is chloride, which either diffuses paracellularly or via secondary active transport with sodium. Urea is passively reabsorbed as well, and it's facilitated by urea transporters present in some nephron segments, especially the inner medullary collecting duct. However, it does not permeate the tubule as much as water and ions because it's bigger in molecular size. Hence, only about half of it is reabsorbed, and the rest is excreted. Now that we're done with the guiding principles of tubulo-interstitial transport mechanisms, feel free to pause this video and refresh your mind for a while. As we are done with the basics of the basics, let us now go through renal reabsorption and secretion segment by segment. As the major site of tubular reabsorption, normally PCT reabsorbs about 65% of the filtered sodium and slightly less for chloride before the filtrate reaches the loop of Henle. However, variations may occur as reabsorption rate depends on various physiologic conditions. One thing that the PCT is noted for is that it has a high capacity for active and passive reabsorption both. The reasons of such are because, first of all, there are numerous mitochondria, which warrants high extent of metabolic activity. Therefore, it can support lots of active transport processes. Second, there is an increased cellular surface area. First, it has an extensive apical or luminal brush borders. Another thing it has is an extensive labyrinth of intracellular and basal channels. Therefore, with surface area increase, there is an equivalent increase in reabsorption and secretion rates for the solutes. In the S1 and the proximal half of S2 segments of the PCT, sodium is reabsorbed into the cell by co-transport along with the most essential molecules needed to be reabsorbed. That includes glucose via sodium-glucose co-transporters, amino acids via sodium amino acid co-transporters, and phosphate via sodium phosphate co-transporters. After sodium is reabsorbed inside the cell to be transported towards the interstitium, it goes through the sodium-potassium ATPase pump. After that, subsequently, H2O is osmosed. Therefore, isotonic fluid is what is generated at the interstitium. Now, as more and more essential nutrients are being reabsorbed together with sodium, there will be a relative increase in chloride concentration in the filtrate. Thus, as it arrives on the distal half of the PCT, there will be a preferential diffusion of chloride from the tubular lumen through the intercellular junctions and into the renal interstitium because of its higher concentration. Despite this, sodium concentration along the PCT would still be relatively constant because of a concomitant water reabsorption along with sodium reabsorption. Also, other organic molecules like glucose, amino acids, and bicarbonate will have a reduced concentration along the length of PCT because these are more avidly reabsorbed than water. Overall, the total solute concentration remains essentially the same all along the tubule because of high water permeability. On the other hand, tubular secretion, together with glomerular filtration at the PCT, plays a vital role for a much faster clearance of end products of metabolism, such as bile salts, oxalates, and urates, and harmful substances like drug metabolites and other toxins that are present in the body. Now, what happens if the entire PCT loses its function? That's the case of Fanconi syndrome, in which there is an increased excretion of amino acids, glucose, bicarbonate, phosphate, potassium, literally all substances that are supposedly reabsorbed by the PCT. This results in metabolic acidosis, a buildup of acid in the blood because there's a lack of bicarbonate at this point, hypophosphatemia because there's a lack of reabsorption of phosphate, and hypokalemia because even potassium can't be reabsorbed anymore. Causes include hereditary defects, ischemia, multiple myeloma, nephrotoxic drugs, and lead poisoning. Now, one thing that is to be taken into account is that because the PCT reabsorbs lots of water, especially in the distal segment, volume depletion is also common in this syndrome. The loop of Henle is divided into three functionally distinct segments: the thin descending limb, the thin ascending limb, and the thick ascending limb. The thin limbs of the loop of Henle, in contrast with the thick limb, have thin epithelial membranes without brush borders and have only a few mitochondria, causing its minimal levels of metabolic activity. The thin descending limb is highly permeable to water and moderately permeable to solutes like sodium and urea to allow simple diffusion of these substances through its wall. However, as the filtrate passes through the thin and thick ascending limb, virtually no water would be reabsorbed because its walls are impermeable to water. The thick ascending limb in particular, aside from it being impermeable to water, it is capable of active reabsorption of some electrolytes thanks to its cells' high metabolic activity. One thing of importance is that in the thin ascending limb, what's important is the sodium-potassium ATPase pump, whereas in the thick ascending limb, a place that is impermeable to water, the important channel is the sodium-potassium 2-chloride symporter. The sodium-potassium 2-chloride symporter of the thick ascending loop of Henle is the primary site of action of your loop diuretics. There are two types of loop diuretics based on their composition in the chemical structure. There are sulfa-containing loop diuretics that would include your furosemide, the most commonly used loop diuretic, bumetanide, torsemide, azoxamide, and pyretinide, and the phenoxyacetic acid derivative ethacrynic acid. Indications for your loop diuretics will include hypertension and edematostates. Furthermore, if you compare it to thiazides, loops promote more potent diuresis, albeit less vasodilation. Adverse effects for loop diuretics are more or less similar with other diuretics. That includes dehydration and electrolyte imbalance due to excess excretion of water and electrolytes. Also included is hypotension due to excess decrease in blood volume. Another issue is nephrotoxicity and ototoxicity, particularly with the sulfa-containing loop diuretics. This is remediable by withdrawing the said drugs. Contraindications would include sulfa allergies and anuria. In the case of sulfa allergies, the provider may ask the person to switch to ethacrynic acid instead. Now that we have talked about loop diuretics, let's also mention that one entity that presents similarly to chronic loop diuretic use. That is Bartter syndrome, an autosomal recessive generalized defect of the thick ascending limb of the loop of Henle. It therefore affects the sodium-potassium 2-chloride cotransporter, therefore contributing to the following effects: metabolic alkalosis because of chloride excretion, hypokalemia because of potassium excretion, and hypercalciuria, which is because, supposedly in normal cases, the sodium-potassium 2-chloride cotransporter's actions would contribute to the reabsorption of calcium via paracellular diffusion. However, in Bartter syndrome, the cotransporter is affected. Therefore, the calcium remains in the tubules and therefore excreted in the urine. After the loop of Henle, the filtrate will empty into the DCT. The first part of the distal tubule forms the macula densa, which is a group of epithelial cells that is also part of the juxtaglomerular complex and provides feedback control of glomerular filtration rate and blood flow in that particular nephron. The next part is a highly convoluted tubule with a set of properties similar to the thick ascending limb, making it the diluting segment of the DCT. In the diluting segment, electrolytes are reabsorbed, and at the same time, not water and urea, as this area is impermeable to the said compounds. Important channels include the sodium-potassium ATPase pump in the basolateral membrane and the sodium chloride symporter, which contributes to 5% of the filtered sodium in the membrane. The sodium chloride symporter is the primary site of action of your thiazide diuretics. Thiazide diuretics end in the suffix thiazide, as you can see in the drugs located in this image. Indications include hypertension and edematous states, as well as nephrogenic diabetes insipidus. Adverse effects include extracellular volume depletion, leading to dehydration, hypotension, and electrolyte imbalance. Contraindications include hypersensitivity, as thiazides contain a sulfa compound. Another thing that inhibits the sodium chloride cotransporter in the DCT is Gitelman syndrome, a generalized DCT dysfunction. So the effects would include metabolic alkalosis due to excretion of chloride, hypomagnesemia, hypokalemia, and hypocalciuria. It is inherited in an autosomal recessive pattern and presents similarly to lifelong thiazide diuretic use. Now let's proceed to the late DCT and cortical collecting duct. There are two cell types in this area. That includes your principal cells and intercalated cells. Principal cells reabsorb sodium and secrete potassium, and this depends on the activity of your sodium-potassium ATPase pump. Potassium would first enter the cell, and once in the cell, potassium would diffuse into the tubular fluid. Intercalated cells, on the other hand, are divided into type A and type B. Type A would secrete hydrogen ions by hydrogen ATPase and hydrogen potassium ATPase transporters, while type B would rather secrete bicarbonate in exchange for hydrogen ions. Now let's talk about Liddle syndrome, in which there is an increased sodium reabsorption in the collecting tubules due to a gain-of-function mutation that is autosomal dominant in inheritance pattern. Effects include metabolic alkalosis, hypokalemia, hypertension, and decreased levels in aldosterone in lab results. However, the presentation of the patient with Liddle syndrome will be similar to hyperaldosteronism. Treatment would include amiloride, which is an ENaC channel inhibitor, which we will talk about later. Lastly, we're now here at the medullary collecting duct, which is the final site of urine processing and therefore urine acidification, which plays a key role in acid-base balance regulation. Epithelial cells in this area have smooth surfaces and few mitochondria, therefore low metabolic activity. Therefore, not much active transport occurs here. Rather, it is permeable to urea via urea transporters, therefore facilitating diffusion of the said compound. And water, on the other hand, has activity that is controlled by antidiuretic hormone. Here is a summary of reabsorption and secretion in the different parts of the nephron. One thing of note is that the concentration of a particular solute present in the tubular fluid will always depend on the relative degree of its reabsorption compared to water reabsorption. In other words, if the relatively reabsorption of water is greater than that of the solute, then the latter will be more concentrated in the tubular fluid. Otherwise, substance dilution will occur when the percentage of solute reabsorption is relatively greater than that of water. Now that we know the step-by-step process of tubular reabsorption and secretion, let's now talk about how reabsorption is regulated in the tubule. Because it is essential to maintain a precise balance between tubular reabsorption and glomerular filtration, there are multiple nervous, hormonal, and local control mechanisms that regulate tubular reabsorption, just as there are for control of glomerular filtration. An important feature of tubular reabsorption is that reabsorption of some solutes can be regulated independently of others, especially through hormonal control mechanisms, which we will talk about here. The glomerulotubular balance is a feedback mechanism to keep a constant percentage of reabsorbed glomerular filtrate. The change in glomerular filtration rate causes a proportionate change in the proximal tubule reabsorption of solutes and water. That is to say, the percentage of reabsorption from the GFR usually remains constant at approximately 65%. An increase of the GFR, on the other hand, would therefore mean an increase in the absolute PCT reabsorption rate. Due to this, a constant fraction of the filtered salt and water is reabsorbed. There are factors that may affect GFR, such as increases or decreases in blood pressure, changes in renal hydrostatic pressure, vascular resistance, and blood volume. As you can see in this synthesized diagram, an increase in the GFR would warrant an increase in concentration of proteins in the peritubular capillaries, therefore increases in the tubular load. Result of this would be a higher peritubular capillaries colloid osmotic pressure. This will then result to an increase in reabsorption in the PCT. This diagram here, on the other hand, demonstrates another control mechanism that regulates reabsorption. That is to say, the peritubular capillary and renal interstitial fluid physical forces. By physical forces here, we mean colloid osmotic forces and hydrostatic forces. As shown in the diagram, the plasma volume is reduced from 100% to 80% as it reaches the glomerulus. The 20% volume that was filtered in the glomerulus would then pass the renal tubules, where more than 19% of the fluid is reabsorbed back to the peritubular capillaries. This means that as the glomerular filtrate would pass the renal tubules, 99% of the water and most of the solutes are reabsorbed. And this reabsorption across the peritubular capillaries can be calculated using the formula, in which the values, as seen, have their normal levels. The Kf, filtration coefficient that is normally around 12.4 milliliters per minute per mmHg, whereas the normal rate for tubular reabsorption goes at around 124 milliliters per minute. Recalling just what I've said earlier, it is shown that the plasma volume from the afferent arteriole towards the efferent arterioles decreased into 80%. Since fluid has been removed or filtered in the glomerulus, this causes an increase in the osmotic pressure of the capillaries. Osmotic pressure is one of the physical forces that regulates fluid reabsorption in the tubules. And tubular reabsorption in the renal blood vessels are explained by the Starling principle, wherein fluid movement across a capillary is dependent on the balance between the hydrostatic pressures and osmotic pressures, both in the capillaries and the interstitial fluid. The net pressure of 10 mmHg, as shown in this diagram, is referred to as the net reabsorption pressure. Now, even the physical forces themselves in the peritubular capillaries depend on 4 factors. These are the arterial pressure, the resistance of the afferent and efferent arterioles, the systemic blood plasma protein concentration, and the filtration fraction, as you can all see in this table. Usually, a normal hydrostatic and colloid osmotic pressure in the peritubular capillaries would cause a net reabsorption with a minimal backleak of solutes and water towards the renal lumen. For an instance where in the peritubular capillary a decrease in the reabsorptive force occurs, this affects physical forces in the interstitium. The interstitium's hydrostatic pressure would then increase, while the colloid osmotic pressure would decrease, thereby decreasing the reabsorption in the peritubular capillary. Aside from these changes, it would also then cause an increased backleak of water and solutes towards the renal lumen. Thus, the reabsorption in the renal tubules is also decreased. A summary of literally everything on physical forces talked about a while ago is this diagram. When the arterial pressure is increased, the kidney's excretion level is also increased through pressure diuresis, the excretion of fluid in form of urine, and pressure natriuresis, an increase in the excretion of sodium in the urine. Both of these are the result of raised renal perfusion pressure, which increases the GFR. Other effects of the arterial pressure on urine output would also include a reduction in the angiotensin II production in order to decrease the tubular reabsorption of sodium, and an internalization of sodium transporter proteins, therefore reducing amount of sodium that crosses the apical membrane of the tubule. That having said, let's now proceed to the hormonal control of tubular reabsorption. 5 hormones affect the extent of sodium, chloride, calcium, and water reabsorption, as well as potassium secretion by the renal tubules. These hormones include aldosterone, angiotensin II, which would also lead to aldosterone production, antidiuretic hormone or vasopressin, atrial natriuretic peptide, and the parathyroid hormones. First, we have aldosterone. It is secreted by the zona glomerulosa cells of the adrenal cortex. The major renal tubular site of aldosterone action is the principal cells of the cortical collecting tubule. Now, what does it do? Aldosterone will exert its action upon the following stimuli. First, increased extracellular potassium concentration and increased angiotensin II levels, which typically would occur in conditions associated with sodium and volume depletion or low blood pressure. Angiotensin II is something we're going to talk about a little later. What aldosterone does is mainly 2 things. First, it stimulates the sodium-potassium ATPase pump on the basolateral side of the cortical collecting tubule, therefore facilitating sodium reabsorption and subsequent potassium excretion. It also increases sodium permeability on the luminal side of the membrane, therefore facilitating even more sodium reabsorption and potassium excretion. Effects include increases in sodium chloride and water reabsorption, and resultant potassium secretion, and increased hydrogen secretion as well. Now, specifically, aldosterone acts on the aldosterone receptor in the principal cells of your late distal tubule and collecting duct. Aldosterone receptor, upon receipt of aldosterone molecule, would then signal the nucleus of the cell to increase expression in 2 channels. First, the ENaC channel, also known as the epithelial sodium channel. This channel is located in the apical surface of the tubule cell. Increased expression of this channel would mean increased sodium influx from the lumen to the cell, therefore facilitating sodium reabsorption. Aldosterone receptor would also cause an increased expression in the sodium-potassium ATPase pump, which is located in the basolateral side of the cell. This facilitates further sodium reabsorption from the cell to the interstitium in exchange to excretion of potassium the other way around. The aldosterone receptor in particular is the main site of action of your mineralocorticoid receptor antagonists, also known as the aldosterone receptor antagonists. Aldosterone receptor antagonists particularly end in the suffix "-one", that includes your spironolactone and your eplerenone. Aldosterone antagonists will reduce the sodium influx, therefore decreasing the electrogenic exchange of sodium for potassium and hydrogen. This can therefore cause side effects such as hyperkalemia and acidosis. Now, another thing to take into account is that Mineralocorticoid receptor antagonists don't just act on the aldosterone receptors of the kidneys. They affect virtually every cell that has an aldosterone receptor. Therefore, mineralocorticoid receptor antagonists are also indicated in cases of hyperaldosteronism, therefore directly inhibiting aldosterone production. Now, this is particularly beneficial in blunting the effects of testosterone in the body, such as in cases of polycystic ovarian syndrome. However, as this contributes to hormonal action, it may cause anti-androgenic side effects that would include gynecomastia, or the development of breasts in men, and impotence, particularly in the cases of spironolactone. Together with mineralocorticoid receptor antagonists, epithelial sodium channel inhibitors are also considered potassium-sparing diuretics. Under this class are triamterene and amiloride. Note that these are the only two drugs under this class. Now, compared to aldosterone antagonists that bind to mineralocorticoid receptors and blunt aldosterone activity, triamterene and amiloride would instead directly interfere with sodium entry through the anax in the apical membrane. Now, effects of urinary excretion would include sodium channel blockade in this part of the nephron where they're acting on, therefore causing sodium and chloride excretion rates. Blockage of these channels would also hyperpolarize the luminal membrane, therefore reducing lumen-negative transepithelial voltage. Volume contraction may also increase reabsorption of uric acid in the proximal tubule. Therefore, it is of note that chronic administration of amiloride and triamterene may decrease uric acid excretion, and there is little to no effect on renal hemodynamics, and they do not also alter the TGF. You've heard in the discussion just a while ago that aldosterone is stimulated by angiotensin II, which is also another end product of the renin-angiotensin-aldosterone system. The RAAS is stimulated by drops in blood pressure and fluid volume, therefore causing renin release from the kidney. Renin cleaves angiotensinogen, an inactive zymogen that is released from the liver, forming angiotensin I. Angiotensin I proceeds to the lungs, where it is cleaved by the angiotensin converting enzyme, converting angiotensin I to angiotensin II. Angiotensin II would then, from its name, angio meaning vessel and tensin meaning tense, act on blood vessels, stimulating vasoconstriction, therefore less blood vessel diameter, therefore increase in blood flow, therefore increase in blood pressure. Other effects would include constriction of the efferent arterioles, increasing blood pressure, and of course, directly stimulating sodium reabsorption in all parts of the tubule. This would include stimulation of the following channels: the sodium-potassium ATPase pump on the tubular epithelial cell basolateral membrane, the sodium-hydrogen exchanger in the luminal membrane, especially at PCT, and the sodium bicarbonate co-transporter in the basolateral membrane. Here is a diagram that shows the direct effects of angiotensin II in order to increase sodium reabsorption. Note that this is in effect in all parts of the tubule. It would stimulate the sodium-hydrogen exchanger on the luminal membrane and the sodium-potassium ATPase transporter, as well as sodium bicarbonate co-transporter on the basolateral membrane. Another hormone that affects tubular reabsorption is antidiuretic hormone. Antidiuretic hormone promotes antidiuresis. Antidiuresis meaning inhibition of diuretic activity. We have noted that diuresis is defined as excretion of urine, particularly water. Therefore, ADH increases water reabsorption. ADH, also known as vasopressin, is released by the neurohypophysis, aka the posterior pituitary gland. Its most important renal action is the increase of water permeability in the following parts of the tubule: the DCT, the collecting tubule, and the collecting duct epithelium. This is the body's way to conserve water in circumstances such as dehydration. Now, ADH would bind specifically to the V2 receptors, therefore causing an increase in CAMP formation and activating protein kinases. Therefore, this would then stimulate the movement of an intracellular protein. This is called aquaporin-2 or AQP2 to the luminal side of the cell membrane. As we have talked about a while ago, way back at the principles of reabsorption and secretion, aquaporin-2 facilitates osmosis of water. So an increased expression of AQP2 would then increase the reabsorption of water from the lumen to the interstitial fluid. It is of note that the action of ADH is AQP2 because other aquaporins, such as AQP3 and AQP4 on the basolateral sides of the cell membrane, are not regulated by ADH. Same case with AQP1. It is also not regulated by ADH. It's always present in the luminal side of the cell membrane, particularly in the proximal parts of the tubule. In this diagram, you can see the vasopressin's action on V1A receptor located in the blood vessels and the V2 receptor particularly present in the renal tubule. It is indicated in red, its actions on the V2 receptor. Once again, it causes a rapid insertion of aquaporin-2, therefore facilitating the rapid osmosis of water, particularly in the collecting ducts. Now let's talk about drugs that have a direct relation to ADH. Vasopressin receptor agonists, that is, arginine vasopressin, are naturally occurring vasopressin-like peptides. They simulate the effects of ADH. Therefore, vasopressin receptor agonists would promote water retention. Other effects of your vasopressin receptor agonists would include concentrated urine, decreased free water clearance, and low amounts of serum sodium. On the other hand, vasopressin receptor antagonists would cause the opposite effects as they antagonize the action of ADH. That includes dilute urine, increased free water clearance, and increased amounts of serum sodium in blood. Vasopressin receptor antagonists are also considered aquaretics as they specifically act on water excretion and not excretion of any other particular electrolyte. Kidneys aside, another part that is particularly sensitive to plasma volume changes and blood pressure changes are the cells of the right atrium. Now, when these cells in the right atrium are stretched in cases of increased blood volume and blood pressure, atrial natriuretic peptide is released. Atrial natriuretic peptide directly inhibits the reabsorption of sodium and water, consequently, by the renal tubules, particularly in the PCT and the collecting duct. It also inhibits renin secretion and therefore inhibits angiotensin II formation, therefore furthering the reduction on renal tubular reabsorption of sodium and water. This then promotes excretion of sodium, aka natriuresis, and subsequent excretion of water as well, because water goes where sodium follows. Last but not the least, in the hormones that affect reabsorption and secretion is the parathyroid hormone. This increases calcium reabsorption and is considered one of the most important calcium regulating hormones in the body. It is stimulated by lower than normal levels of calcium in the blood. This would then stimulate their production in the parathyroid glands. Its principal action in the kidneys is increased tubular reabsorption of calcium, especially in the distal tubules and the loop of Henle. Other actions include inhibition of phosphate reabsorption, therefore promoting phosphate excretion, and stimulating magnesium reabsorption in the loop of Henle. From the feedback loop promoted by this hormone, you can notice the dynamics between these three electrolytes. Calcium and phosphate have an inverse relationship, whereas calcium and magnesium have a direct relationship. Not to forget is the action of your sympathetic nervous system, which is, when activated, increasing sodium reabsorption. It occurs by activation of your alpha adrenergic receptors on the renal tubular epithelium. What happens next is that renal arterioles are constricted, therefore reducing GFR, and therefore increasing sodium reabsorption in the PCT, the thick ascending limb of the loop of Henle, and the more distal parts of the renal tubule. Also, with S and S stimulation, renin is also released, and angiotensin II is therefore formed, which adds to the overall effect of increasing tubular reabsorption of sodium and decreasing its renal excretion. Note that this is particularly activated in cases of decreased volumes of water in the body, in a case called hypovolemia, which is one of the conditions that cause pre-renal azotemia. Now, we're getting near to talking about the three subdivisions of azotemia, but before that, let's talk about clearance and its related variables. As we are nearing the talk on azotemia and tubulointerstitial diseases, it is pertinent that we know about clearance and its related variables. Let us now discuss the different ways of quantifying the effectiveness with which the kidneys excrete various substances. Here are the formulas for clearance and its related variables. Renal clearance is defined as the volume of plasma that is completely cleared of the substance by the kidneys per unit of time. This provides a way of quantifying the kidney's excretory function and the rates of renal blood flow, glomerular filtration, tubular reabsorption, and tubular secretion. From the formula as shown, you can conclude that the following are needed for an ideal substance to compute a person's renal clearance. First, all of it must be cleared by the glomerulus. 2. None of it must be reabsorbed by the tubules. 3. All of it must be excreted in the urine, and therefore, 4. None of it must remain in the plasma. With these criteria, we can then formulate that the filtration rate of the substance in the kidney is equal to the formula above. Now, if you rearrange that formula to isolate GFR, GFR will then equate to the quotient of the urine concentration times urine flow rate divided by plasma concentration. This is simply equivalent to the clearance rate of a substance, as you can recall from the formula a while ago. A substance that fits these criteria is inulin. Inulin is freely filtered in the glomerulus and is neither reabsorbed nor secreted by the tubules. Therefore, it is the gold standard in determining GFR, and thus gold standard in determining clearance. It is a plant-based polysaccharide molecule that is not produced in the body, aka it is an exogenous compound. Therefore, to measure GFR via inulin clearance, it must be administered intravenously. That is why, despite being accurate, usage of this substance is not practical. Therefore, other than inulin, we can utilize other substances. Most commonly used substance to estimate GFR is creatinine. Creatinine is a byproduct of muscle metabolism that is cleared from the body fluids almost entirely by glomerular filtration. This is because creatinine is small enough to pass through the glomerulus, but relatively large that it is impermeant to any point in the renal tubule. Other than that, it is an endogenous substance, therefore does not require IV infusion. This is why it is much more widely used than inulin. An approximation of changes in GFR can be obtained by simply measuring plasma creatinine, which is inversely proportional to GFR. The standard formula for creatinine clearance is as shown. However, since the laboratories do not utilize urine creatinine measurements much anymore, now we estimate creatinine clearance via Cockcroft-Gault formulas, MDRD, Schwartz formula, Barrett's formula, and other formulas that have existed and have been talked about in the previous lectures. As shown in the figure above is the effectivity of creatinine in measuring GFR and therefore renal damage. This is because a sudden 50% decrease of GFR will cause a transient filtration and excretion of only half as much creatinine, therefore causing an accumulation of creatinine in the body fluids and raising its plasma concentration. The lower figure then shows that plasma concentration of creatinine will continue to rise until the filtered creatinine and creatinine excretion return to normal levels, and therefore a balance between creatinine production and creatinine excretion is reestablished. This diagram shows that GFR and plasma creatinine concentration is inversely proportional. That is to say, for example, a decrease of GFR to 1/8 its normal level would then raise plasma creatinine to 8 times the normal level. Thus, creatinine excretion rate would equal the rate of its production despite reductions in GFR. Another variable in renal function is renal plasma flow. To assess renal plasma flow from the clearance rate, ideally it should be number 1, completely filtered, number 2, not reabsorbed, and because GFR is only 20% of total plasma flow, the substance should also be completely secreted. Therefore, the amount of substance delivered to the kidneys in the blood, which is renal plasma flow times the plasma concentration, would be equal to the amount excreted in the urine, which is the urine concentration times the urine flow. When rearranged to isolate renal plasma flow, you can check the formula, as indicated. There is no known substance, however, that is completely cleared by the kidneys. So, to estimate renal plasma flow, we can utilize para-aminohippuric acid, which is about 90% cleared from the plasma. This is mainly due to its rapid clearance from the system, thanks to its high tubular secretion rate. To be more accurate, one can use the extraction ratio of PAH. An example is indicated in this image, where the plasma concentration of PAH is 0.01 milligrams per milliliter. Urine's concentration is 5.58 milligrams per milliliter, and urine flow rate is 1 milliliter per minute. Thus, clearance of PAH would then calculate to be 585 milliliters per minute without the extraction ratio. Now, if the extraction ratio is 90%, as we have mentioned a while ago, the actual RPF can then be calculated by dividing the answer, 585 ml per minute, by 0.9, which gives us a value of 650 ml per minute. We can then utilize GFR and RPF in the calculation of the filtration fraction, which is the fraction of plasma that filters through the glomerular membrane. In calculating filtration fraction, one must know the renal plasma flow via para-aminohippuric acid and the glomerular filtration rate, which is via inulin clearance. An example is stated as follows. One can also calculate whether there is a net reabsorption or a net secretion of a substance by knowing the GFR and the rate of renal excretion. If the rate of filtration is more than the rate of excretion, that means some of the substance has been reabsorbed, whereas if it's the other way around, it means there has been additional tubular secretion going on. Now, all those basics and math seem complicated and overwhelming to a first-time learner. Thus, we hope that we've made things easier for you. The gist, however, is this. Any compromise in any of the renal functions, that is particularly glomerular filtration, tubular reabsorption, and secretion, highlight renal pathology, as renal pathology would then equate to a large magnitude of dysfunctions in the body. Renal pathology would include kidney injury, which causes azotemia, or the retention of waste products such as BUN and creatinine. And finally, we're going to talk about it shortly. For now, let's take another pause before we move on to the last leg of this discussion.
Having heard of the basics of renal reabsorption and secretion, let's now proceed to the clinical side of things. So when the renal system of our body is unable to properly filter waste products, this could result in the elevation of nitrogenous waste. Azotemia is a biochemical abnormality which is defined as the elevation of nitrogenous products, creatinine in the blood, and other secondary waste products in the body. Azotemia is important when discussing the causes of acute kidney injury, wherein there are three subtypes: the pre-renal, the intrinsic or the intrarenal, and the post-renal azotemia. Pre-renal azotemia is the most common form of acute kidney injury. The common causes include hypovolemia and decreased cardiac output, in which there would be a reduced total or intravascular fluid volume, which decreases the glomerular filtration rate that would then lead to renal hypoperfusion. Pre-renal azotemia can also be caused by impaired renal regulation caused by medications such as NSAIDs, ACE inhibitors, and angiotensin receptor blockers. These medications will also cause a decrease in glomerular filtration rate that leads to hypoperfusion. Next is the intrinsic azotemia, which results from structural damage of the different parts of the kidney, including the glomeruli, the renal tubules, the interstitium, and the renal vasculature. So later, we will be talking more about tubulointerstitial diseases. So intrinsic azotemia often results from ischemia and septic injury. It can also result from endogenous and exogenous nephrotoxins. Now, in postrenal azotemia, there is usually obstruction to the urinary flow from the renal pelvis to the tip of the urethra. Causes may include bladder neck obstruction, obstructed Foley catheters, lower tract and ureteral obstructions. Now, for the clinical features, findings associated with pre-renal azotemia includes vomiting, diarrhea, tachycardia, systemic or orthostatic hypotension, and dry mucous membranes. In intrinsic azotemia, there could be history of nephrotoxic medication, contrast exposure, and there could also be signs of sepsis and ischemia. On the other hand, in postrenal azotemia, there could be history of kidney stones, prostate disease, obstructed bladder catheter, or retroperitoneal or pelvic neoplasm. Other significant findings can be assessed upon laboratory evaluation. The blood urea nitrogen creatinine ratio and the fractional excretion of sodium helps in differentiating the causes of acute kidney injury. The fractional excretion of sodium is measured by the percentage of filtered sodium that is excreted in the urine. Bond creatinine ratio in pre-renal azotemia is greater than 20, while in postrenal azotemia, it is less than 20. In intrinsic or intrarenal azotemia, the bond creatinine ratio is less than 10 to 15. For the fractional excretion sodium in pre-renal azotemia, it is less than 1%, while it is greater than 1% in postrenal. Then for intrinsic azotemia, it could either be less than or greater than 1% depending on the nature of the disease. Urinalysis may be normal in pre-renal azotemia and in post-renal azotemia, but in pre-renal azotemia, there may be presence of hyaline casts, while urinalysis may reveal biuria or hematuria in post-renal. In intrinsic azotemia, urinalysis may reveal casts, biuria, hematuria, or proteinuria. Treatment or management for azotemia or in azotemia may include IV fluid hydration for the reestablishment of adequate perfusion to the kidneys. Another is the cessation of toxic substances that is also followed by hydration. Management of hypertension and diabetes mellitus, if present, is also essential since this can adversely affect renal vascular and tubular epithelium and renal interstitium if poorly managed. And in case of obstruction in postrenal, relief of obstruction followed by hydration is the mainstay. Now let's talk about tubulointerstitial diseases, which also causes intrarenal azotemia. So tubulointerstitial diseases are a group of disorders that primarily affects the renal tubules and the interstitium. They are categorized into acute tubulointerstitial disorders and chronic tubulointerstitial disorders. There's also a subcategory of metabolic disorders that lead to chronic kidney disease if untreated. So there are different mechanisms of inflammation in tubulointerstitial nephritis. This include cellular injury that may be caused by infection of bacteria or viruses or other microbes, or it could be caused by ischemia. Another mechanism is the hypersensitivity to drug or toxin, wherein the drugs will act as haptens. So haptens are small molecules that bind to a larger protein to become immunogenic. So when the drug molecules bind to a larger molecule in the extracellular compartment of the tubular cell, it will elicit an immune response that will trigger the activation of T cells. Going back to cellular injury, this will lead to the infiltration of inflammatory cells such as macrophages and lymphocytes in the kidney. This will lead to the activation of cytokines that can also trigger the activation of transcription factors. So, along with the activation of T cells, these processes result to the disruption of renal function. which is reversible. But when it becomes chronic, there would be progressive development of interstitial scarring, fibrosis, and tubule atrophy that could eventually lead to chronic renal insufficiency. So for the first category of tubulointerstitial disorders, we have acute tubulointerstitial nephritis, which defines a pattern of renal injury that is usually associated with a deterioration in renal function characterized by inflammation and edema of the renal interstitium. It is most often caused by medication, hence the subtype allergic interstitial nephritis, but it can also be caused by an infection or by an autoimmune syndrome. Beta-lactams, cephalosporins, sulfolactic shocks, and NSAIDs are some of the top causes of allergic interstitial nephritis, while diseases such as diphtheria, legionellosis, tuberculosis, and others that can be caused by the microbes listed in this table result in infection-associated acute interstitial nephritis. Autoimmune syndromes such as tubulointerstitial nephritis with uveitis and systemic lupus erythematosus can manifest as acute interstitial nephritis, and also obstructive disorders or selective tubular defects can also cause acute interstitial nephritis. Fever, rash, peripheral eosinophilia, and oliguric renal failure are classic presentations of acute interstitial nephritis. Typical manifestation also include the history of drug hypersensitivity, recent infection, or antibiotic intake. There is also variable degrees of hypertension. Laboratory evaluation typically reveals a rise in creatinine with a fractional excretion of sodium greater than 1%, with no expected acute tubular necrosis and or glomerulonephritis. The kidney size may be normal or increased. Hematuria with mild proteinuria may also be evident. Urinalysis may reveal presence of white blood cells and white blood cell casts. So on biopsy, acute interstitial nephrosis is demonstrated by leukocytic infiltration that typically spare the glomeruli until late in the course. So for the treatment of acute interstitial nephritis, the principal intervention is to discontinue the offending agent or to treat the infection. Acute interstitial nephritis is usually responsive to glucocorticoid therapy, but is usually reserved for cases with severe renal failure. This is because glucocorticoid therapy doesn't really impact the long-term renal survival. Although patients may require maintenance therapy with other immunosuppressive agents such as methotrexate, azathioprine, or mycophenolate. Now, in chronic tubulointerstitial nephritis, there is inflammation of peritubular or interstitial spaces that lead to interstitial scarring with fibrosis, lymphomonocytic infiltrate, tubular dilation, and atrophy. Features of chronic tubulointerstitial nephritis are more indolent and may manifest with disorders of tubular function. The most common etiologies of chronic interstitial nephritis are medication-induced lesions and infections, but there is also a wide variety of diseases causing chronic interstitial nephritis, including heavy metal toxicities or exposures, chronic obstructive nephropathy, reflux disease, immunologic disease, metabolic disorders, and ischemia. Typical manifestations of chronic interstitial nephritis is the same with the signs and symptoms of renal failure. This includes hematuria, hypostenuria, which means an abnormally low urinary specific gravity, nocturia, fatigue, and nausea. Laboratory evaluation also reveals elevated levels of serum creatinine, while on urinalysis, the specific gravity is about 1.010. Urinalysis may also reveal non-nephrotic range proteinuria and the presence of RBC casts, white blood cell casts, or granular casts. So on biopsy, chronic interstitial nephritis is manifested by interstitial fibrosis with patchy mononuclear cell infiltration and widespread tubular atrophy, luminal dilation, and thickening of tubular basement membrane. Treatment of chronic tubulointerstitial nephritis usually depends on the etiology. It generally consists of supportive measures such as adequate blood pressure control and management of anemia. With metabolic disorders, severe increase or decrease in electrolytes or metabolic products will lead to the formation of tubular lesions or the deposition of crystals. That could result in tubular obstruction. So the formation of lesion can also lead to tubular cell damage or tubular necrosis that could result in obstruction. So eventually, tubular atrophy and dilation accompanied with fibrosis may ensue, leading to chronic kidney damage. So these are the types of metabolic disorders, or these are some of the types. First, we have chronic uric acid nephropathy, also known as gouty nephropathy. This is associated with high uric acid or hyperuricemia. Then we have hypercalcemic nephropathy, which is associated with chronic hypercalcemia in diseases such as primary hyperthyroidism and sarcoidosis. Next, we have hypokalemic nephropathy, which is associated with severe hypokalemia due to diuretic abuse or primary aldosteronism. So those are some of the types or categories of tubulointerstitial. With that, we thank you for having listened to this lecture. Hopefully you've learned a lot, especially what's needed regarding this topic. If you have questions or if you found those secret messages, just contact us through Facebook Messenger. Have a great day, happy studying, and rest well.